Everyone, let's talk about hypoglycemia. Hypoglycemia means reduction of the glucose in the blood. It is the commonest side effect of insulin and sulfonylurea drugs, usually in the treatment of diabetic patients. It is a potentially fatal problem. In children, maybe single tab of sulfonylurea might be fatal for a child. It results from imbalance between the glucose supply, the food that you take, the utilization, metabolism, and also the insulin levels that the patient is having. For example, if the patient is taking the insulin and not taking the food, so there will be hypoglycemia. It is defined as a blood glucose that's less than 4 millimole per liter. Cognitive functions deteriorate at levels less than 3 millimole per liter. So glucose level less than 70 milligram per deciliter can be defined as hypoglycemia. Less than about 50 or 54, the patient will get disturbance in the conscious level. What are the causes? The most common cause is relative high insulin compared to the food that you take. So insufficient or delayed food intake and excessive exercise or excessive insulin intake may result in hypoglycemia. This is the most common. Other causes are alcohol-induced hypoglycemia, patients who are on alcohol, especially those who get liver disease. Liver failure is also a common problem leading to hypoglycemia. Others like Addison's disease, pituitary disease, post-gastric surgery, malaria, insulinoma, which is increase in the secreted amount of insulin due to a tumor called insulinoma, other extrapancreatic tumors, and also overdose of insulin or oral hypoglycemic agent, especially when the patient takes it wrong or in suicidal attempts. What are the clinical features of hypoglycemia? It can be classified as autonomic symptoms and neurologic symptoms. What are the autonomic symptoms? Sweating, palpitation, shaking, and tremor, hunger, and nausea. So these patients usually get these symptoms if they have a good autonomic functioning. And when the glucose level decrease, they will have these symptoms. What about neurological symptoms? Starts from confusion, drowsiness, odd behavior, incoordination, irritability. There is difficulty in speech. It looks like a stroke. Sometimes they have even focal neurological deficits. These focal neurological deficits are very random. They do not have a exact anatomy. There might be hemiparesis, and then they may get into seizure and coma. So some people, because of uncontrolled diabetes, or they have prolonged period of because they have hyperglycemia over a long period, they will have hypoglycemic unawareness. What do we mean by that? It means that they don't have a proper autonomic function. So the patient will not have sweating, palpitation, or shaking, or things like that. They will get sudden neurological symptoms. They will get sudden coma. What are the investigations you do for hypoglycemia? Of course, the most important thing is a blood glucose. A bedside glucometer may be enough for most of the cases. Sometimes you may want to confirm in the lab by IV, by blood test. Liver function test if you suspect liver failure. Serum potassium and ECG also important, because when you give glucose, it might lead to hypokalemia. Sometimes if you are suspecting insulinoma or you suspect overdose, you may send for C-peptide and insulin. Why is that? Because insulin is combined to C-peptide in the beta cells of pancreas. So once they are released, the C-peptide will be separated from the insulin. So the amount of the insulin will be equal to the amount of the C-peptide if the patient is having insulinoma, because it is a normal insulin that is secreted in the body. But if the patient is taking only insulin outside, I mean by subcutaneous or by IV or by any other route, they will get only high level of insulin without increase in the C-peptide. It means that they are in an overdose state. What's the management? If the patient is conscious, they have to take the glucose orally. First quick acting, then long acting carbohydrates like biscuits and toast. But if the patient have lost consciousness, you have to insert an IV cannula and give 10% glucose in 50 ml boluses. If you have 50% hypertonic glucose, then you can give it in 20 ml boluses. Whatever available, you have to give it as a bolus. What we mean by bolus, it means that you have to give it over less than 1 minute until the blood glucose and the conscious level improve. If you don't have an IV, you may try a glucagon if available. A glucagon 1 milligram IM could be used, but it is not suitable for patients with hypoglycemia due to sulfonylurea or liver failure or chronic alcoholism. If IV is not accessible and glucagon is not available, according to the WHO basic emergency course, that you can put some glucose under the tongue sublingually. So glucose sublingually can also be effective. But oral glucose usually is dangerous if you give it too much, because if in patients with loss of consciousness, because it might lead to aspiration pneumonia. If the patient is having sulfonylurea overdose, you have to use octreotide. If the patient have decreased awareness of hypoglycemia, the patient didn't feel hypoglycemia, suddenly they lost consciousness, it means that you have to tell the patient to stop the driving or to inform the driving vehicle license agency. In patients with hypoglycemia secondary to long-acting insulin or sulfonylurea, it means the overdose, you have to admit the patient and give continuous infusion of 10% glucose, 100 ml per hour. So when you want to discharge the patient should be having normal level of consciousness and they have no evidence of other illness. The blood glucose is greater than 4 millimole per liter. It means more than 70. And thank you.